It is a huge honor today to be interviewing a real role model of mine, Eric Jackson. I feel like we have so much in common. We're both DDS. We're both masters in the Academy of General Dentistry. We both have our fellowship in International Congress Oral Implantology and on and on and on and on. And I have really gone to school following you on social media too. I mean, you were the first person I know who you just did it all right. It was your social media posts are educating, informative. I always want to read them, and I can just imagine how your patients wondering. How are you doing today?
I'm doing fantastic. Thank you. Thank you for the kind words. That's fantastic. I mean, coming from someone like yourself with admittedly some of the top posts around means a lot to me. Thank you.
Oh, hey. And so I want to start off. I mean, there's so many things I could talk to you about. I mean, you're a master clinician. You're an implantologist. You're a successful businessman. You're the top 0.01% social media marketing that I've ever seen, and I've been on social media pretty big time since 1998. First of all, I think I want to start was getting you have so many initials behind your names. Talk to these young kids. Was it important looking back? Was joining the Academy of General Dentistry and earning your fellowship and then going on to earn your mastership, looking back, was that a good idea for you?
It was immensely important. I've been very fortunate to meet some of the best people in dentistry through the AGD. And, I was very blessed. I went to University of Illinois at Chicago for dental school. But in the end, I'm sure you can attest, that only starts you out. That's your basic building blocks. And then you got to start kind of expanding what really interests you and what's the real world way of doing things. And I found all that through a variety of ways through the AGD, mentorship and all the different classes. And then all of a sudden you start stringing a few classes together and you say, oh, wow, what's that fellowship about? And maybe I could get a nice goal for myself. And then that becomes mastership and so on and so forth. Continuing education and the people that you meet through it, a fantastic, fantastic thing for me in my career.
I look back and I think that was the single game changer I did in dentistry. And yep. I tell a funny story because when I was getting my fellowship in the Academy of General Dentistry, back in the day, you had to have 500 hours and then pass an all-day exam and practice 5 years. So it was about 100 hours a year for 5 years. And they kept wanting me to take these classes in subjects that I didn't do. I didn't do orthodontics. I didn't do implants. So I complained to my local, and they said no. And I went all the way up to the very top. And this older guy just said, he said, Howard, you got to be cross-trained.
Yep.
And, Carl Misch says that he didn't become a great implantologist if he wouldn't have had his foundation in removable. He said what got him interested in implantology was that these people putting dentures over implants, and the implants were breaking, and they were blaming it on the implants. And he said, no, it was you don't understand how to make a denture. You got to get the bite first.
That's right.
And if you put a bunch of implants in and the bite's horrendous and they don't function properly, then everything's going to go whack. And he credits mastering dentures as his groundwork to mastering implantology.
I've always said it's all about reverse, especially with implants. It's reverse engineering the case. Whether you kind of figure out your destination and then you bring it back to where you are now, it really helps to kind of set the path for the patient, and the treatment plan just kind of flows out of you. All right, well, I need to have implants here, here, and here if possible. How are we going to do that? And we can kind of figure that out that way.
And I don't want to piss off a bunch of people, but I will. Some of these things that these TMD experts say, you can tell they've never done one case of orthodontics. I mean, about at least 20% of everything they say just goes out the window if they just did a few orthodontic classes and treatments.
Well, and that's the benefit of having the fellowships and the masterships of the AGD behind you. You're able to sit in a lecture or listen to a presentation and really kind of decide what works for you. And after you've heard hours and hours and hours of this, you're able to kind of figure out what jives with your own philosophy. And I know I'm the son of an orthodontist, and
I should have made that comment.
No, but you're 100% correct. You have to be multidisciplined, because if you don't appreciate what the orthodontist can do, in their wide scope, then how can you apply even some of that as a general dentist? And the concepts of, just tooth movement, for example, whether you're doing Invisalign or you're doing the veneering cases that could instantly straighten people's teeth, that's really important. It's the foundation that's just no longer are you locked into one avenue of dentistry. It's absolutely melded more than it ever has been before.
And the MAGD also set the groundwork for my mind for Dentaltown, because as I was joining the MAGD back in '87, and I was realizing that I was thinking when I would get back from these courses that the most I learned was from the people I meet and with having lunch with them and going to the bar afterwards and having cheeseburgers and watching the football game. And it's like I would go back and I'd have 6 pages from the bar of notes and 4 pages from Dale. And that's when I saw the internet, is that if we could just all get together and start talking, we would all win.
Absolutely. I mean, Dentaltown in itself is essentially the exact mode of what you want. You want to be able to rub elbows with people who are better than you and different than you. And then in turn, once you get better, then you can rub elbows with somebody who needs your assistance. I'm sure one of the main reasons why you founded it. It's why it's such a fantastic resource to the profession, because whether you're God's gift to dentistry or you just graduated yesterday, there's something on there for everybody. And it's no different than rubbing elbows with your local organizations or your regional, or in this situation, you could be rubbing elbows with somebody in Malaysia on Dentaltown and really learn how they're doing it, and vice versa also.
And then to you young kids, that just got out of school, I want to remind you that we all know what we know, but we don't know what we don't know. And I'm sure 1,000 years from now, a lot of everything we believe is going to look crazy.
Oh, absolutely. I've always joked my grandkids are going to laugh and say, Grandpa, you screwed titanium screws into somebody's head. Why didn't you just grow the tooth in a petri dish like everybody else does these days? I'm like, but we're cutting edge right now. It all changes, and especially these days, so rapidly. With the dissemination of information and the overall knowledge pool just doubling, annually or every 6 months, it just really makes it all the more important to stay on top of your stuff as a dentist.
So the youth, there's a lot of people talking about the oral systemic link, that the mouth is connected to the rest of the body. And do you think that importance is growing in our lifetime right now?
Oh, absolutely. I mean, between the classic topics of diabetes and cardiac issues, but now it's the link between dentistry and medicine the gap between dentistry and medicine is blurring more than ever before. I mean, in my office, I'm proud we've branched out and we do things from genetic testing, the salivary genetic testing when applicable. What else? Brush biopsies. I mean, simple little things that really, really benefit patients. Why not offer a multidisciplinary approach that encompasses not just the multidisciplines of dentistry, but also that of some of medicine? A biopsy brush is not that technical, and especially when you have a fantastic team behind the actual histopathological report. You're in business, and you're able to really help a lot of people. And it happened last week. Woman didn't know what this bump was. Right there, you can help and start getting some information a couple of days later, rather.
Do you want to go into more details about that? Because I'm sure 99% of the listeners have never done any salivary genetic testing or...
Oh, sure. It's fantastic. I mean, it's literally my big thing, 3 things in dentistry I've always preached. I mean, dentistry is such a philosophical type field now. If I can do something that's high impact or high results, low cost, and low invasiveness, if you can get those 3 things, then you've hit your trifecta, right? Salivary testing, literally, you swish with a solution, you spit in a cup, and you send it to a laboratory, and they're able to decipher a million different things from, is there HPV present? What types of strains of HPV is it present? That's wonderful for throat cancer. You can also do it for periodontal type issues. That stubborn scaling root planing case that doesn't respond. Well, there's a couple reasons why it could, and one of them could be some really nasty bacteria of certain strains that are kind of resistant, more or less, to traditional SRP methods. So you have to use a combination method of perhaps some antibiotics or a laser or a combination of both. Really giving you an extra step, because if you know what the name of the bug is, well, then you can go after them a little bit more focused.
And it's interesting to me where, when I got out of school in '87, AIDS was just coming out big time. And now here it is 28 years later, and the world is just barely waking up to the fact that babies are not born with these bugs, and we transmit them from their caregivers, mainly their mother. And
Absolutely.
some of these people that have untreatable periodontal disease are going home and kissing and trading saliva every night with some husband who hasn't been seen by a dentist for 20 years, and it's just not even dawning on the dentist or the patient to say, we need to get your husband in here. I mean, it's kind of silly because if you were treating her every 3 months for chlamydia, you eventually say, who are you sleeping with? And if she said, just my husband, it's like, well, we think he's got the bug too.
You got to talk to him.
So that salivary test, what company are you using?
I use Aura Risk. Aura Risk, ORA Risk. Yeah, it's a fantastic company. They do quite a few different things via the saliva. Like I mentioned, HPV, periodontal type testing, real nice.
And the interesting thing about those bugs is real Christians saying that every 3 months they discover a new species of bug in the mouth.
Absolutely.
Every 3 months. And
the nice part is you've got trained professionals who can help you identify that. And then they figure out what targets it. And you don't have to do it for every case. But, instead of just seeing someone limp along in somewhat healthy perio for years and eventually equals a slow decline, you can really nail down those toughest percents of cases.
So did your dad ever forgive you for not being an orthodontist?
Yeah, no, but my father he is fantastic. And, he still teaches down at the orthodontic department at UIC. And never once did he ever push me towards it. In school, I was always drawn to the exercises where we basically had a treatment plan. And that's kind of what kind of convinced me that I belong more in general dentistry. Kind of then was the genesis towards all the different multidisciplinary approach and the AGD fellowship classes and things like that. I enjoy sitting down with somebody fresh and deciphering what they need. Maybe it's one filling, maybe it's 100 million different things. But because there's so many, for lack of a better term, bullets in my gun, right? In our office, we can do almost 80% of all dental procedures. We still refer out plenty. But the nice part is we have deep, intimate knowledge of everything, all the different disciplines, and that really transfers into the initial treatment plan. Because, as always, the old cliche, the general dentist, whether he or she's doing the actual treatment or not, is always the quarterback of the case. And you're able to then direct where needed and, more importantly, advocate for the patient. You're their home dentist. You need to be able to translate the dentalese into layman. And it works out really nicely that way.
Well, maybe this would be a great time to ask you one of the biggest controversies among practice management consultants is, the patient calls up and the number one reason they call a dental office is that they want a cleaning. And so if a new patient calls up you and you're this multidisciplinary person and says, I want a new patient cleaning, how do you handle that?
The answer is essentially I've got our certain ways. I always like sitting down for a comprehensive exam first. We can do, if necessary, obviously a limited, a quick exam, but that won't get you into the cleaning department. It won't get you into the hygiene department. And just simple patient education. It's effectively if you're blowing people's mind when you tell them, well, we need to figure out what kind of cleaning you need. What do you mean there's multiple types of cleanings? I didn't know there's multiple types of cleanings. And you go through the different types of cleanings, different levels of invasiveness, et cetera. And just that alone, just being able to sit down and explain that one fact to them, let alone the rest of it. Like my comprehensive exams are about 90 minutes long.
Can you go over that, the specifics of it? I bet a lot of people would want to hear that.
Sure.
What is the new patient? If I called up your office and I said, I want to see Eric because he has the same name as my first son, Eric Farran. Yeah. And so I chose you just on your name, Eric. What happened? So you walk us through that. You scheduled me for 90 minutes and how does that actually work? What happens first in the order?
Of course, they come in the office. We sit down actually in this room where I'm at, my consultation room, and myself, the patient, and typically my assistant, we just sit down and we kind of just get to know each other a little bit. I need to know where you want me to take you, what your major goals are, your past experiences, pros and cons to those, your likes, dislikes about the past experiences. So that way we can hopefully, get a glimpse of you in a snapshot in time. We got to be able to build. I always say at that appointment, we're not just taking one little look at you today. We're putting the very first brick of a 40-year wall. You know, and we're going to be building a big giant house, and this is the cornerstone appointment. We need to make sure we're very thorough, and all things come from today. So then after that, we sit down for a good, 10, 15, 20 minutes or longer for whatever it takes. That's why we like to have that much time. We'll go to the operatory, of course, radiographs, photographs, and a big thing for me, I'm very interactive with the patients, I think. It's very important to be that way because I'm a visual learner. So I've got my big screen TV. It's a good 40-inch TV up in front that's linked to my computer behind them. So that way, all the photos, all the x-rays, if I see something that's interesting, we put up right there, and it becomes almost a mini lecture. I'll say I'm kind of deputizing the patients into, almost a dental degree. They need to know not all dentistry, but their mouth dentistry. And it really helps with, obviously, appreciation of what we do as a dentist on a daily basis, but also what's going on in their mouth. Maybe they've got stuff to do. Maybe it's totally pristine. But there's always things to talk about. I mean, in someone's mouth, whether it's a crazed line here or a little bit of recession over there. Maybe they're brushing too hard. Maybe they're grinding. And the different links between things. We look at, obviously head and neck, and we talk a lot about tonsils and obstructive sleep apnea, and then pediatric dentistry. It's a really wonderful, there's no one set conversation, which is why that's my favorite appointment. I love doing comprehensive exams because it's back and forth, just like we're doing here. I mean, there's no set script. There's no set, of course, there's bullet points you have to hit, but really it's just very honest conversation with a patient. And that's what makes 40 years of enjoyment between a doctor and a patient, I think.
Yeah, and I think that separate that new patient meeting the dentist first is
absolutely.
It just totally differentiates your practice as opposed to scheduling with a hygienist and just getting their cleaning and their prophy. And what's also funny is the number one reason new patients come into my office and left their last dentist, the number one reason in my office, and it's almost solid for 20 years. Well, I just wanted a regular cleaning. They said I needed a deep cleaning. So obviously they didn't earn the trust, the respect. Yeah. They didn't show them the x-rays. They didn't understand it. They didn't believe it. I just passed on an attorney because I was setting something up, and he couldn't explain it to me or my president. I mean, we listened to him for 1 hour, and then when he left, it's like, okay, do you understand wills? I don't. I mean, I'm not dumb, but I should be smart enough after 1 hour. I should understand a will for my 4 boys. You know what I mean? I didn't understand it.
I've been very blessed. I've got a patient Rolodex full of what I call high dental IQ patients, right? They're very smart, but they're not dentists. They're not in the dental field. They can get it. They absolutely understand what we're talking about because in the end, dentistry, whether it's fancy implant dentistry, like you said before, whether you're building like Carl Misch backwards to front, but it's still just building. It's construction. What's a post? It's like a piece of rebar. Lots of analogies. Intelligent patients can really get that because they want to. They want to be part of it. They don't want to just lay there and say, "Fix me, doc." That's not what the modern patient, I find, desires these days.
And I think a lot of people have heard the saying that journalists say all the time: explain it like you're explaining it to a 6th grader. And a lot of people sit there and say that comes off that, oh, well, that you mean explain like they're dumb. And it's not that they're dumb. It's like, I'm a dentist. I'm not a plumber. I'm not a mechanic. When I take my car into the shop, he has to explain to me like a 6th grader understanding of auto mechanics. I mean, I grew up playing Barbie dolls with 5 sisters. I never changed the oil, transmission. I don't know any of that stuff. And I play the music so loud, I never hear the engine warning signs or, just if the light comes on, I take it in there, and I need them to explain it to me, like a 6th grader. So a big fan of these podcasts. I mean, thousands of them listen to this are pretty much juniors and seniors in dental school, or they just been out 5 years. I mean, those are the podcast people. So you've been out a long time, and you've made great achievements. What multidisciplinary skill sets should they learn? I mean, would you just recommend they join the FAGD and do all 16 deals, or what do you think? What areas like I think of you as a implantologist. I really do. I would. Yeah. I think of you as an implantologist. Do you think these kids should start signing up for hands-on surgical courses and learn how to place implants, or Do you do molar endo? What type of multidisciplinary do you do?
Well, the thing is, you have to find out what you love. I don't. I love certain things, and actually, it's most things. That's why it ends up being such a large basket to choose from. But if I had to pick one thing, and I've talked to students whenever I give lectures in front of students locally and whatnot, and even some study clubs, it's always if you're not socket grafting, if you're the general dentist that can pull a tooth, every general dentist should be able to pull a tooth. But if you're not actually placing and doing socket preservation at the same time, well, then I feel that that's something that you first off should be doing. So that skill is absolutely imperative, I think. So anytime somebody comes in my office, and it's excluding wisdom teeth, they're always getting to talk about preservation of the bone, preservation of the socket, even if they're not implant candidates, because at some point they might choose to, in the future. Well, now what? Now you've wasted the most precious time to place that and preserve that socket. So coming out of school, and obviously these days especially, it's all about differentiation. If you can differentiate yourself from the guy or girl down the street, and it doesn't change for you and me, frankly, then you need to be able to do something a little bit different. Being able to provide the service of pulling a tooth and placing the graft in there in a wonderful, simple manner makes the world of difference for future treatment.
And do you mind walking us through your socket grafting technique? And
Sure.
And they always like to hear specifics, like like when you say bone grafting, like what material, what name brand, where would they order it? Just can you walk us through your bone grafting technique?
Sure, I'm a big fan. I mean, I've tried a lot of different ones, but it still comes back to I use the way I was trained on. It's a 1-to-1 mix of periglass and demineralized freeze-dried bone. I know you can use your putties, and I've tried a whole bunch and just different sizes, and not every socket graft is exactly the same. I mean, sometimes you'll break out your A or versus your B, but in general, I like a mixture of periglass and demineralized freeze-dried. It works very, very nicely. It's tried and true. I've done thousands and thousands and thousands of them, and I'm not a big fan of being the first on the block to experiment more or less on people.
Oh, I know.
If it's been out, there's the eye clinic there's a wonderful, it's called the Wheaton Eye Clinic down the street from my office here in one town over. And I know they do some of the best work in the state, let alone the region. But they don't offer certain things until they've been out of the market for 7 or 10 years. That's just company policy. Now, I don't have a hardcore company policy like that, but the rationale is very sound. We got a great new product. Why don't you try it out? You mean product test on my patients? No, these are my patients. Why don't you tell me some studies, and then we'll go from there. And that's, again, dental town. Some people are more apt to try new things. Some people are a little more conservative, and I can learn from them just by going on there. And that's just a wonderful way of just being able to communicate.
Oh, my God. When I got out 87, I mean, I've gone through, cement and die course with Duralon. I went through, when I started getting into implants, I got my fellowship Mission Institute, and we were replacing HA coated.
Yeah.
I got burned so many times that I think when I turned about 40, I said, you know what, until other colleagues have done it for 5 years successfully, I'm not even going to listen. I mean, I paid my dues.
Totally agree, because in the end, even if you're correct, there's always that one that's just not as great a result as I would like. And, that's not what you want to say. That's not the kind of office I want to run. And so in the end, from the very get-go, from the time I started the office, I decided I'm not going to do that. Okay. It's going to end up being tried and true.
Okay, is Periglass just periglass.com, periglass.com?
I believe so, yes.
And yeah. Where do you buy that from?
We got our Periglass from, actually, we just recently switched. The Periglass and the bone, for a while I was getting through Straumann, because I used Straumann implants I actually exclusively. I really like their product. Again, that's a whole other podcast, I'm sure, for you. But I've always enjoyed how the Straumann restore. And as a restorative dentist, that's obviously imperative. I mean, it's not just the surgical portion we're putting in there. It's how do they look? Are you able to make some beautiful custom abutments? And how well do they stand the test of time? So for me, there's a lot of different places where you can get your bone and your Periglass for that matter. But if it comes down to, I've always gone through my rep, because it's one more reason why you really have a great strong rep. Reps these days are sometimes being replaced by PDF files, and And that's okay to some extent. It's technology, but it sure is nice to have a living, breathing human being who really knows his or her stuff.
So you're talking about the Straumann rep.
Yeah, Straumann rep.
Yeah, you know what? I would say, I'm kind of confused by dentists because they should be really, really smart, but they're not really classically trained in business or economics, which is why I went back on my MBA. But, Implants Direct said, okay, we're going to go lower costs by selling them online. And then so everybody starts buying them because they're lower in cost, and then they all start complaining about not having a rep. And it's like, are you not right in the head?
No,
and now they're putting reps in, and it's like, and their parent company Danaher bought no bug here. But I'll say this, you can buy the cheapest implant from countries all around the world, from Russia to Korea to Israel, whatever. But when I meet a dentist like you, like Tarun Agarwal, like so many people that are actually implementing it and placing a lot of implants, they all pay higher dollars for their implants because they value that relationship with the rest. So I call it just getting her done. It's kind of like why I have a personal trainer knock on my door at 5 o'clock, because the first 50 years didn't happen. And I thought, okay, if it didn't happen the first 50 years, probably not going to happen in the second half either. So I don't really care what we do at 5 o'clock. What I'm paying for is getting her done. Yeah. And the people that are getting her done, placing, like how many implants would you say you place a month or a year? Or?
Oh, I don't know for that, but in general, it's been, I guess in the last, in the last decade, it's over 2,000 implants. I mean, easily.
And anytime I meet someone like that, they pay for higher quality implants for the rep. Now, how much of this is for their, now, is Straumann, I always get mixed up. Are they from Sweden or Switzerland?
Switzerland, yeah.
Switzerland. So now, are you liking Straumann because you like the local rep, or do you like Straumann for technical reasons?
I used to place, early in my career, I was at an implant center exclusively. So all we were doing was implants, big cases, things like that. And upon, realization that after I was there for a couple of years, I realized I missed a lot of general dentistry. And then my true calling was to really integrate implants into the day-to-day cosmetic dentistry that we were all kind of familiar with, a family dentist. So in the end, I chose the Straumann company because, yeah, they had a fantastic rep, but, I was also looking at Nobel. But for me, the big thing was I just felt right in my hands, and sometimes and I know that sounds a little wishy-washy, but just comes down to, you just kind of, you're picking up the Nike or the Reebok and you're like, wow, these are both great. I kind of like this one more. I don't know why. It just looks nice to me, or it feels nicer in my hand or on my foot. And I think that's kind of exactly what happened. It was just kind of, you were drawn to it. And, fortunately, you're choosing between apples and apples in that situation. I mean, obviously, two of the largest implant companies in the nation, or in the world. So you can't go wrong. It's just a matter of what works well in your hand. Like so many things that we do. Do you prefer A material or B material? Do you like 3M, or do you like Bisco, or that kind of stuff? And they're all wonderful. It's just a matter of what you kind of prefer. A little more viscous here, a little bit less that. And I really think that's part of the hardest part about coming out, like you said, for the first 5 years, the podcast, they're all young dentists. You got to try a bunch of stuff in a responsible manner, like we said, without testing on people, but you also have to be able to know what works well in your hands. And the best way to do that is hook up with some really good, experienced dentists, see what they use, and try out. It's that way you're not necessarily randomly picking through the Henry Schein or the Patterson book.
About 10 years ago, I was having dinner with Gordon Christian and the CEO of Dentsply at the Chicago airport, John Miles, and he said something to me very profound. He said, dentists are very brand loyal because they have so many procedures that they have to do that if something works in their hands, they're not going to change because of an ad or a flyer or a discount or whatever, because they have so many things that they're trying to improve in another area. If they're taking an impression and it works, they'll use the same impression material for 10, 20, 30, 40 years. He used to always believe that dentists were more brand loyal than any group of people out there. Just because you're always working on the weakest link in the chain, you're sure as hell not going to start changing what's been working for you for 5, 10, 20 years just because they got a new color or a flavor.
Exactly, and because, and I think that obviously dentistry has and dentists in general have certain reputations and whatnot, but dentists are really good people. I think in a large part, we're not trying to well, this will get you 5 seconds faster. I don't care about 5 seconds faster. I literally couldn't care any less. I want to make sure, is your new product just as good as the one you're replacing? And if not, then you can keep your 5 seconds. I don't need that.
I know. I love dentists. I really do. I mean, whenever you stay in a dentist home, the thing that I always notice the most when you spend a night in a dentist home, they always have 100 nonfiction books. And whenever you stay in someone who's not a dentist or physician or lawyer, they have People magazine and 50 Shades of Grey, and dentists are just smart. They're well-read. And since they're classically trained in all the basics of science, whether it's math, physics, chemistry, or biology, they're actually really spot on in areas of science outside their expertise, whether it be global warming or mercury. I want to ask you about that. There was well, first of all, I need to go back to socket grafting. Do you put a membrane over the top of that and suture that in, or?
Sometimes yes, sometimes no.
What makes you do it and what makes you not?
Well, I mean, in the end, most of the time I'll do a PTFE type membrane. Nothing, pretty traditional. I don't really use that many of the titanium mesh. And then sometimes I'll just place the traditional a traditional gel foam over the top of it. If it's a real small little fella, it works out really well. There's pros and cons to each one, and you have to pick the right scenario, of course, just like everything we do. But really, it's you get great results, and in the end, as long as your graft, especially the particulates that I use, as long as it stays in there, you're going to be getting some great results.
And some listener might not have understood what PTFE means.
Essentially, it's plumber's tape, right? That's the whole idea. A nice little plumber's tape over the top, but a whole lot more expensive than medical grade. So it's going to be able to keep that material in place, because unless you're getting primary closure and actually getting the gums, the gingiva, etc., to close over and hold it in, well, it's a particulate. It's going to be like sand falling out of. I always compare it to like sand falling out of a coffee cup. You don't want that. You want it to keep the coffee in the coffee cup. So you got to cork it off, and so that way you're in good shape.
And how do you charge for that? And does insurance pay anything?
Oh, you want to be the number one. Well, actually, there's a lot of reasons I'm blessed, but my staff here is fantastic about. I mean, we can bill out to medical sometimes, not always, but sometimes. And yeah, more and more dental insurances are covering implant placement and socket grafting. Probably more the implants, I guess, right now than the socket grafting, but. In the end, I price both my implants and my socket grafting, especially my socket grafting, probably quite a bit lower than I should, just because I want them to be done. I want the socket graft to be placed in there. I don't want it to be a big, well, I don't know, maybe not. It comes down to everything's better with more bone. And you know what? Let's put it in there. Let's make sure it's done right.
And if your extraction fee was $1, what would your bone grafting fee be in relationship to? Is it 1-to-1? Is it half to 1, 2 to 1?
It's about 2 to, well, a little under 2 to 1.
So it's twice as much money for the bone grafting as it is for the extraction.
Yeah, the bone grafting, it comes down to exactly right. That's about right.
Yeah. And anything else you want to say about Straumann or the rep or anything about that?
They're fantastic. I mean, in the end, especially for the younger people watching, the actual brand of implant, like you said, if it works well in your hands, you can use a cheap one, you can use an expensive one, but just know what you're using. You can use multiple ones for that matter. I mean, there's nothing wrong with having multiple different systems in your office. But as a young dentist, you may not have that availability to you, whether it's your own office or your funding. They're expensive. So it comes down to, I like the one that does a little bit of everything, which is lovely.
Next time you see your rep, tell your rep the thing that still blows my mind the most is that Noble Biocare, Straumann, ITI Straumann, none of these major companies, or even Resnick, Implants Direct, none of them put a 25 to 50 hour from A to Z how to place implants on Dental Town, and it has 202,000 members. And they took those 250-some courses like 500,000 times. And, I mean, you would think if you owned an implant company, and they have all the courses.
Sure they do.
They have, man. That's been crazy.
They got the research, they got the development, they got everything at their disposal.
Yeah, you should tell your rep that's still the most overlooked deal. And if I owned the company, I'd put up tomorrow. So then the big thing is, what about a CBCT? Did you actually buy one, or do you just have access to one? Because that's a big chunk of change.
It's a big chunk of change. I've got access to one. We've done everything from, I'm in the western burbs of Chicago. There's actually quite a few around. Specialist friends of mine have them. There's even mobile units that can come by. And actually, the mobile units are sometimes some of the best and most convenient because the patient's already here. They literally walk outside the mobile unit.
You use that, huh? You use a mobile unit.
It's been wonderful. Not exclusively, and sometimes it's nice to be able to have the different technologies. Everyone's got different systems and things like that. But truly, the mobile units have been should not be overlooked. Put it that way.
What percent of the time when you place an implant do you use the CBCT?
Well, for me, my office and my implants consist of predominantly 1, 2, 3 at a time. Maybe occasionally we're crossing the arch, but really a lot of my patients have all their teeth. We're not doing the super large, full rehab hybrid type cases I used to do in the past. So it's much more of converting a bridge to an individual's. For that, it varies. It varies, but the vast majority I still don't use. A good solid Panorex from our Panorex is really the mainstay, I'd say. And then of course you have it if you need it. The CBCT can be ordered left and right.
And what percent of these? Well, first of all, explain. You said you used to do a lot of complex cases, and now you're doing more. Instead of a 3-unit bridge. Why did you migrate from a lot of complex cases to more just not doing a 3-unit bridge?
Well, back before when I was an associate, I was working at an implant center, and that was kind of the genesis of all my my real-world surgical skills, we'll call it. And we didn't see children, we didn't see anybody under 18. It was only implants all day long, every day of the year. And a lot of crown, a lot of bridge, a lot of all the pros part of it too. And then at some point, I kind of missed the variety of general dentistry, and so I was able to take that and incorporate that more into the family dentist modality. The downside, though, is that there's always a pros and a con. You can't necessarily have the same focus and experience for the patient, but also the dentist, as a surgical center when when you have to do several hygiene checks, or there's a child down the hallway that's a little bit upset about getting his teeth cleaned. It doesn't jive that way. So I've kind of cut back on the larger cases. Because truly, in my neck of the woods, that's not the bulk of the cases for me. For every one giant case that comes through, which is really not terribly often, there's dozens of the 1s, 2s, and 3s that we just put in.
And I always thought that was the strangest thing about dental continuing education is that you go to a convention, they have like these TMJ courses, and TMJ is not 1% of the average dentist revenue, and then they have all these cosmetic courses of upper 10 veneers, and that's not even 1% of a dentist revenue. And then you go to an implant case, and they're showing all these full mouth reconstructions, and most people in the room, at least half have never done one case ever, and the other half have only done, they count all those cases on one hand. And then when you sit there and say, well, what do dentists do all day long? 96% of crowns are done one tooth at a time. 96% of implants are placed one at a time, and nobody wants to talk about that because it's just not super sexy, and
it's not glamorous. It's not sexy. You're right.
Yeah,
it doesn't sell tickets, but it is. It does. It's the mainstay of it, and especially in a well-controlled, hygiene population, our patients, they brush their teeth. Their teeth are great. I mean, initially they come in off the street, fresh to the office. Maybe they've got to do some work, but you know what? Through a lot of the patient education and the actual value that you place on not only the doctor-patient relationship, but also just their teeth in general. Your teeth are not disposable. They're very important, and your quality of life will suffer unless you start changing things a little bit. And so, just by basic tenets like that, which we all try to do, things get pretty stable pretty quickly. And especially with effective communication.
So when you're placing when 96% of implants get placed as one at a time, and you have a tooth in front and a tooth behind, what percent of the time do you use the surgical guide versus just eyeball it and place it?
I'm a big surgical guide guy. I think it's important. It's how I was trained. I really like it quite a bit. It's, I guess you can always freehand it, I suppose. I mean, there's plenty of people out there, but that's just I'm a big surgical guide kind of guy, especially when you're doing multiple times. But like you said, when you've got one in front, one behind, the angulation pretty much needs to match. I still like and it goes back to the reverse engineering. I want to know where the crown's going to be. And just being able to visualize it in that small piece of plastic or acrylic, it means a lot to me.
Walk us through your surgical guide. There's so many that people talk about.
Mine aren't anything very complicated. It's essentially, it's you can make a very quick version of it. There's lots of different kinds, but some of my favorite, especially for the simpler single cases, you got a box of old denture teeth. Take your model, pour it all up, place your denture teeth at appropriate size in there, and that's a pretty good approximation about where the tooth's going to be. Get your suck down, get your vacuform material on there, and you've got yourself a wonderful surgical guide that's going to keep your nose pretty clean.
So you're making, you take upper and lower alginates, you pour up the models, you put a denture tooth there, and then you do a suck down over that?
Yeah.
And then you drill a hole on the model, or?
I'll drill a hole, on the model where I want it, which is nice, and then you can just kind of extend that hole up through the plastic. And then your surgery kind of just becomes, for lack of a better term, it's semi-guided, I guess. You've already got the desired hole there, and you just got to match A to B.
Very good. And what do you have any favorite implant software from CBT? If you got a CBT, is there a designing software, or is that not really a big passion of yours?
I don't have any solid allegiance to this one software. I mean, plus it's changing so often, and it's not like I said, it's not my norm to use it every single time. So I don't have a particular allegiance at this point.
A lot of people don't want to get a CBCT because they think the half-life of the technology is only 5 years.
Well, I agree, and plus it comes down to, to be truly effective, you're taking a lot of CBCTs on people. Well, I have children in the office, and that's a whole debate where I'm still, again, I'm waiting a little bit more. Let me see a little bit more research on it, whether you're going to extrapolate out. I mean, how wonderful is it that you can take a CBCT of somebody and extrapolate out the pan and the bite wings and the full mouth and everything. But with that said, it's how necessary, and more importantly, when you're going to have to buy a new one to stay up with the Joneses.
A lot of dentists are, they come out of school $250,000 in debt, and they're wondering, do I need a $150,000 CAD cam? What would you say to a kid like that? Do you have one?
I don't CAD cam, no. I still think the laboratory is of vital importance as far as making high-end restorations. I've got several friends that do wonderful work with CAD cams, but you just can't, at least in my opinion, at this point, replace the human element of it all. They can mill it, they can do it, but it comes down to when you need custom shading, when you need somebody there that's truly an artist in it, especially for the anterior cases. And I know that's not necessarily for every office, because you can do very well with and succeed with the speed and efficiency. A good friend of mine is able to do it in half the amount of time that I am, and that's wonderful because the patients truly value that. There's no second appointment. It's you wait there and you mill it, and then there's no temporary, and that's really, really nice in some respects. For me, at least right now, I'm looking at the scanners technology as they're coming through. I like the idea of being able to ditch the impression material. I think that'll be a really fun day when we no longer have to take semi-gelatinous goop and gag people just to make a nice crown or a bridge. Being able to do that remotely without any powder or dust, and I know it's right around the corner to be really, really predictable.
Do you mainly use one lab, or do you use a half dozen different labs?
No, somewhere in between. I've got I use a lab that's for my posterior restorations. I've got one that's kind of for my anteriors and my implants. And I've got one that's removable. So I've got actually 3.
Are they all in Chicago?
Yeah, they're all local. Yeah, and I think that's really important too. The benefit is I'm in Chicago. I mean, I'm not in the middle of nowhere. And there's just the density of it all. I'm very blessed to have these people literally in my backyard. I mean, several of them are just a couple towns over. And being able to send the patient, all right, Mrs. Jones, you're going to go down to the laboratory. The actual clinician who's going to make your appliance is going to actually, draw you and shade you and get everything out. It's a very nice way to do it. And it really imparts a lot of, and plus the patient, they love it because they can literally say, I want it to look more like this and like that, and they bring them back for a little shade check. It's wonderful service. That takes a lot of the load off my end. Because when you're dealing with anterior teeth, hey, fit is good, but the cosmetics is just as important.
Our podcasts are usually downloaded in 206 countries on every episode, and so the viewers around the world, Eric actually lives in the city of Chicago where the American Dental Association is on
That's right.
211 Chicago Avenue. Is that?
Yeah, that's right. Yeah.
Yeah, and I remember that from writing my check to him.
That's right.
I think all the American dentists want to ask you, why does the Chicago Midwinter hold their? I mean, I love Chicago. I think it's one of the coolest cities in the world. I've been to so many countries: Chicago, New York, San Fran, San Diego. I mean, those are like San Antonio, maybe. But anyway, so why do they have the Chicago Midwinter in April? Why isn't it like rocking us in May or October or around Halloween? Why is it February when it's to our viewers around the world, Chicago almost touches Canada. It's way up north, and it's on the tip of a lake. So you always have a wind chill factor coming off, and they have it in February. It's like that would be the exact month I would not have it. Why do you think they do that? You think it's just
They like the maybe it was a little ego thing. Siberia is what they were calling it last year, right? It was about as cold as it gets. But it comes down for me historically February and September, I guess, are always a little bit slower months because people are kind of getting back into things, especially with school in September. I imagine that's probably the genesis, but that's just pure speculation on my part.
Whenever I ask the old guys, I always get the same answer. We've had it that same weekend, 1850 something, before.
That's probably more accurate than my explanation, too.
I think they were having that meeting before the Civil War at that time there, because no one seems to know. It's always been the same day. So then everybody's wondering, do you screw your crowns to implants or not? We keep hearing a lot that one of the biggest causes of periimplantitis is excess cement, and some implantologists just say they're not cement anymore. What are you doing?
I don't. Well, see, the thing is, obviously with the screw, you're going to have the visible access screw, and then you can use opacers and things like that. But I don't screw. But I do always make a custom abutment. I really want that cement line up as high as possible away from that implant, just like a natural tooth. So whether it's a CAD/CAM brand name like Atlantis or something along those lines, just being able to have a beautiful wide platform that mimics just more or less a perfect ideal crown prep. And then you simply just have to clean around the half millimeter below the gum line, and you're in great shape. Very predictable. Obviously a nice radiopaque cement so you can see what the heck you're dealing with on the X-rays, and you're in business. But CAD/CAM custom abutments and I go along very well with my implants. I don't use stock abutments.
Eric, how would you answer this? I'm in Phoenix, and there's two dental schools in my backyard. One's in Glendale and one's in Mesa. And when they're in my office, the most common question I get is, the problem they have with implants is the person who usually lost the tooth had decay and gum disease, and they're just thinking, well, what's going to last longer on that missing tooth? The person already has a mouthful of virulent periopathogens, Streptococcus mutans, and what would you say to a kid who said, Eric, the person who lost his tooth had a huge cavity and a bleeding 5 millimeter pocket, so his mouth's filled with bugs.
Yeah.
What would last longer, an implant and a crown there, or a 3-unit bridge? How would you explain that?
What I would tell those the young dentists would be, it really comes down to what we talked about earlier: a really good comprehensive exam, knowing has it been 30 years since they're at the dentist? I mean, if they don't have a true value for things, if they don't understand that implants aren't necessarily forever. I mean, you hear it on the radio all the time with the implants. Oh, these are forever. Well, they're not unless you take care of them. And even then, they haven't been around that long in their single-rooted form to really be able to make that kind of claim. So that patient better be well-educated, certainly as clean as possible going into it. And then it comes down to, obviously, a lot of patient responsibility. For me, it's funny. I'll have people coming to me for implants, and I'll just, I'll joke with them. I'm like, I'm going to talk you out of this implant right now, Mrs. Jones, because you need a bridge on that tooth. Whether it's they're looking at the space, and I'm looking at the space and the neighbors. The two neighbors have 15 pounds of amalgam in them from 1922. It's not going to be very long before those need some help too. Why don't you go with the bridge, Mrs. Jones? Kill two birds with one stone. That's where again, it's full circle. True comprehensive dentistry is multidisciplinary, being able to choose between implant and crown, being able to look at the entire mouth, evaluate the gums, evaluate the flora of the mouth, their past histories. It's a very complex, time-consuming appointment that all happens in that 0150 comprehensive exam.
One of my very good friends, they ear, nose, and throat, and You don't want to get them started on sinus lifts. It's going to be a rant forever. And I think it's funny how dentists say, well, I'll never do a bridge because I don't want to file the enamel off the tooth. And then they'll put half a bucket of sand in the person's sinus. And then my ENT front buddy, Gordon, saying, no, so it's funny how a dentist, the enamel's sacred, but they'll destroy the sinus. So an ENT is like, leave the sinus alone. It's sacred. File down the teeth. And it's funny how everybody has their own perspective. And as you get older and older and older, you just realize that binomial thinking is a red flag. When someone says, always yes, always no, up, down, right, not left, whenever you hear an extremist, you know the truth's in the middle somewhere. And as you get older and older and older, you get more and more moderate and realize that every question is complex. In fact, when I'm asking you questions, I'm half the time thinking, did I ask that question right? I mean, how you ask the question is everything.
You can't, nothing is absolute, right? That's the old saying. And it all comes down to, patient care. Each patient is different. Each treatment plan is different. You have to know both the physical and the emotional backgrounds. You got to know a little bit of everything to truly get that patient what they want. Because in the end, and even then, that might be, I may have even misspoke there. It's what they want and what they need and what you can achieve. All these things kind of come together at the end of that appointment. It's a very interesting thing because your ENT friend, there's no one way to do things, and I'm sure there's some definite validity to that opinion, and I'm sure there's some definite validity to the dental aspect of it as well. So it comes down to, you're absolutely right. Being able to do it multiple different ways is imperative.
One of the things that you're a role model and an idol to me is you always have one eye on your patient's needs, but you also have an eye on cost, and you factor that in a big way. And you're a big part of the CDS Foundation Dental Clinic and the DuPage County Health Department. I want to, and thank you for that. But I want to ask you this: you can't even go a month or two, and there's something in the news about mercury, and a lot of these young kids are saying, well, what about amalgams for poor? It's so confusing. Again, it's extremely complex because we know amalgams last at least twice as long as composites. Well, hell, they're bacteriostatic. I mean, mercury, silver, zinc, copper, tin, every one of those is antibacterial to some degree. They're cheaper. But right now they're in San Diego, the scientists are talking about, they're finding a lot of mercury in the seal lions, their hair. And it's showing up in, I think they're saying mollusk, whatever that is. But I read that the main mercury contamination for the ocean is burning coal. Coal goes up in the air, it goes over the oceans, it settles, and that's the mercury deal. But then some people are pointing out clearly to me that somewhere around 5 or 6% of atmospheric mercury is coming from cremating 3 million humans a year, and their amalgams are actually going into the vapor. So my question to you is: you work for the poor, you volunteer for the poor. What do you say to a young kid who says, is being amalgam free, is that extremist? I mean, what do you think about amalgam? Do you use it in your office? Do you use it in your clinics? Do you use it at the CDS Foundation Dental Clinic or the DuPage County Health Department?
I can only speak for what I kind of believe. I don't introduce any new. I always talk with the patients. I don't introduce any new amalgam to the party. Am I the one that's harping about you got to get all that out of your mouth, right away? No. But when I have to remove any, no new amalgams going in. So I don't place. I haven't placed an amalgam fit personally in 6-10 years. Who knows? Quite a long time. I'm blessed also. You touched on the economics of it all. The beautiful part is the Chicago Dental Society Free Clinic is such a great organization that they give really a lot of carte blanche autonomy to the providers. If you wish to place amalgam, go right ahead. They've got it there. If you wish to place only a resin like I do, you've got it there. You've also got time. You're not there's no expectations to put in 37 fillings in an hour. It's not a race. You're treating good working class people who are either the working poor or the under the poverty line. And it's nice because you're able to do it in a way that I would do exactly for the same for my patients and my paying patients in my office. So long-winded answer to your question, but I don't introduce any new to the party for the same reasons you said. There's a lot of question marks out there, And yeah, there are some positives to it, but there are quite a few negatives. And every year that goes by, you got to wonder. And again, no sense in experimenting in people. Plus, in the end, let's be honest, the cosmetics of it all, and people don't mind having the nice white matching fillings. It's quite nice.
Yeah, every once in a while I'll hear a dentist always tell me, I at least once a month some dentists say, well, I don't pull teeth or place implants because I don't like blood and guts.
Yeah.
I always think, well, how the hell did you end up in dental school? I mean, you should be
I agree.
working at Intel. I mean, my iPhone doesn't have any blood. But I always tell them, you know what, you should then do extractions at crematories because they really need to pass laws that someone needs to go in there and extract those teeth before they cremate them. So if you don't like blood and guts, maybe you could be a cremation amalgam extractionist.
You wouldn't have to use a whole lot of Novocaine either. That'd be great.
Yeah. You wouldn't have to worry about bleeding.
Yeah.
So, Eric, the thing that I seriously can't think of a single dentist or a single company that does social media better than you. I mean, even the people who have the big companies, and I look at their stuff. I mean, it's good and everything, but in all seriousness, yours is the best. My question to you is, are you the one doing all that? Do you outsource that to a company? And has it been a return on investment for you? I mean, is it worth it? Do you get new patients from it?
Oh, absolutely. Oh, it's been a tremendous asset. Yeah, I do everything myself. And it's the old adage, it's write about what you want to read about, I'll write up if I'm feeling a little bit more surgical. I have an office newsletter that I started. And it's all about patient education. One more way that I don't have to have a long diatribe with patients while they're here in the office, because they've got places to go and people to see. But if they really want to learn about how and why I do the Invisalign the way I do, the Invisalign experience with Dr. Jackson, it's all on the website. You get a fun little video, a fun little this. You pepper the actual things in there that relate directly back to my office. But also the internet is such a wonderful thing. Put a funny Pinterest quote up there that you like on Fridays. It's Friday Fun Day. It's all the different little things you want, and it's kind of just a reflection of what's in my head, I suppose. And I guess that's a lot of different directions. So if it resonates with someone like yourself, I'm a very happy man, and it's been wonderful. It's just a really great way to disseminate information, deputize the patients into being a deputy dentist.
I mean, I really feel like I know you. I mean, I feel like from your following your social media, how long have you been doing it? I mean, since about, what would you say, 2009?
Yeah, about 2009. Yeah.
Yeah, I've been following you since 2009. I mean, I feel like you're my neighbor. I mean, I feel like I really know you.
And that's the whole, that right there, that's why. I mean, what's the best way to get to know your dentist? Well, you can spend a lot of time with them, but that's usually when you're getting work done, and that's fine. But you can absolutely do it just from the comfort of your own phone and just kind of know what goes on in his or her head. Plus, it's just, hey, social media costs effort. I mean, I've got people calling me all the time. They want to take over this or they want to ghost write for that, and that's not me. I want to make sure that the words coming out of my mouth are actually the words on the page, and vice versa. How could
someone listening to this right now follow you on social media?
Oh, I think we just recently passed 3,000 Twitter followers, and so I'm real pleased for a local Downers Grove, outside of Chicago dentist. I think I'm remarkably proud of that.
What's your Twitter? At what?
At E Jackson DDS.
At E Jackson DDS.
DDS, yeah. And obviously, there's a little bit of everything. It's from the YouTube channel to the Facebook and Twitter to even just a little more obscure things like LinkedIn. You'd be surprised. I mean, the reps, and I'm able to get a hold of a rep like that because sometimes I'll have their card, sometimes I'll have their LinkedIn account. A quick message, and there you go. They're right there. I mean, they're the business people. We're dentists. We don't really deal with business in the same way. But you know what? I don't need an actual business card. I've got your contact information right there, and it's wonderful. You'd be surprised how often I get that weird look that said, wow, no one ever follows me on LinkedIn. Yeah, that's important. This is business. We're doing business here.
Yeah, and your posts are amazing. And when I follow your posts, you obviously feel you're very likable, and your cases and implants. You just feel like you're going to an authority. You don't feel like you're going to some kid who doesn't know what they're doing, or some wishy-washy, or someone who's focused on insurance or something. You feel like I'm gonna go there, and this guy totally knows what's going on, and he's just gonna get it done.
That's the beauty and the curse of social media. You put yourself out there, and for better or for worse, it's very transparent, and you can kind of put the generic pre-made posts from your provider up there, but truly, it's one of those things where I prefer the real thing. I want to make sure that that's all correct. That's all the true representation of me.
I'm out of time. We're right at 60 minutes. I got one overtime question for you. You mentioned Invisalign. What are your thoughts on Invisalign, and what would you say to someone who says, there's a couple of companies out there doing it, or do you like Invisalign? Have you tried other ones? Do you think that's a significant part of your practice?
It's like everything else. I never have one part of my practice that's more significant. It's funny. It comes in cycles. You'll get a bunch of implant cases all of a sudden, and then you get a bunch of Invisalign cases all of a sudden, and then you get a bunch of crown and bridge type cases, and it just kind of all ebbs and flows like that. That's what really makes me a very happy general dentist. I like variety. I like being able to dabble in a little of everything. The way I do Invisalign, it's a little bit different. I mean, there's lots of different ways to do it. I don't charge for workups at all. I think it's a really nice service. It's because I'm not doing a tremendous amount of it. I'll just enjoy sitting down after work and then just work up a case. Then I'll have the patient come on back. And I mean, it's a rare treat to be able to sit down with somebody and say, here's what I think visually you can look, and here's what I think your case is going to end up like. What do you think? Because usually, with the orthodontist, in non-Invisalign type cases, it's all between the ears. I can do that in 9 months, in 2 years. But the nice part is being able to really visualize or show the patient. It means the world. It also gives them ownership. They know what's happening. It's no different than a blueprint for your new house that you're going to build or your office building that you're going to construct.
So some orthodontists are not shy at all of the fact that they don't think general dentists should be doing ortho. Has your dad ever told you at the dental table, son, you shouldn't be doing Invisalign? No,
because he instilled in me a long time ago that, and it's very apparent, Invisalign can't do everything. I'm very against Invisalign can just replace braces. And there's plenty of people out there that more or less either say it or, treat like that. You can't do certain movements predictably. That one case that you were able to move, that molar over here to the other side of their face, that's a 1 in a billion shot. And I'm not going to do 1 in a billion type procedures on my patients. I want to know nice traditional tipping, twisting, a little bit of extrusion, that kind of thing. Very traditional. So I'm I'm an old soul when it comes to Invisalign. But the nice part is their technology gets better and better. And when I don't think that it can be accomplished with Invisalign, well, then I've got some beautiful specialists, lined up right there down the street.
Well, Eric, you said you lecture sometimes at your study clubs and stuff.
Yeah, I have.
If you got an hour lecture, I'd give anything to have you put it up on Dental Town.
I'd love to.
Yeah, I would absolutely love that because I just think you're a hell of a guy. You're a hell of a clinician. You're a hell of a social media. I just think you're a hell of a guy. And I just want to tell you, we're 2 minutes over time, but thank you so much for spending an hour with me today. I just think, and thank you for all you do for dentistry and your the CDS Foundation, the DuPage County Health. I mean, everything. You're just a hell of a guy. Thank you so much for spending an hour with me today.
It means a lot coming from a guy like you. You're somebody that I've sat in your lectures and your MBA for dentistry courses and things, and it's just fantastic being able to sit here. This is exactly what I wanted to have when I was young. First year out, second year out, being able to rub elbows with somebody the likes of Howard Farran or the likes of anybody else in that league. I mean, really, we're talking A-list people here, and here I am sitting Skyping with you, and it's fantastic.
Thanks, buddy. Well, thanks, and I hope you have a rockin' hot rest of the day.
You too. Thank you very much.